Your patient's creatinine was 0.9 yesterday. Today, it's 2.1. What happened? Is it dehydration? Is it sepsis? Drug toxicity? Or something worse? Hello viewers, myself Dr. Mukib, presenting you with a very new video. In this video, we'll break down acute kidney injury, how to diagnose it early, classify it, investigate it properly, and decide when dialysis is needed. Stay with me to see the video. What is acute kidney injury? Acute kidney injury, also known as AKI, is a sudden decline in the function of the kidney, leading to, first, there will be rise in serum creatinine. The second, the urine output will be reduced. Third one, there will be electrolyte imbalance. Fourthly, there will be metabolic acidosis. And according to Kidney Diseases Improving Global Outcomes Criteria, KDIGO, AKI is diagnosed if the serum creatinine is increased more than or equal to 0.3 mg per dl over last 48 hours, or if the serum creatinine is increased more than or equal to 1.5 times baseline within the last 7 days, or the urine output it is less than 0.5 ml per kg per hour for the last 6 hours. Now, what are the types of acute kidney injury? The first type of acute kidney injury is the pre-renal AKI. It is the most common type of AKI seen in 60% of the cases. And the causes for pre-renal AKI are: 1. Dehydration, 2nd sepsis, 3rd one is shock, 4th heart failure, and burns. And now the key feature for pre-renal AKI are: kidneys are structurally normal, but the problem is decreased renal perfusion. And the second type of AKI is intrinsic AKI. The causes for intrinsic AKI are like acute tubular necrosis, glomerulonephritis, interstitial nephritis, and some drug toxicity like NSAIDs, aminoglycosides, or some contrast. And the third type of AKI is post-renal AKI. And the causes are like benign prostate hyperplasia, BPH, stones like nephrolithiasis or ureteric calculus, any tumor in the kidneys or ureter, bilateral obstruction of the ureter. These are the causes for post-renal AKI. And we have to rule out the obstruction with ultrasonography like UHG, kidney, ureter, and bladder. Now, about the investigations. So the basic lab investigations to be done in AKI are like: we have to check for the serum creatinine level, we have to check for urea, we have to check for electrolytes, especially potassium level, and we have to check arterial blood gas analysis to rule out metabolic acidosis. And about the urine test, we have to check for routine urine and microscopy, then urine sodium, then fractional excretion of sodium. And in radiology or imaging department, we have to do ultrasonography abdomen or KOB. Then we have to check bladder retention. Now, how to differentiate between pre-renal and acute tubercular necrosis? So the parameters are like: in pre-renal, the urine sodium will be less than 20, but in acute tubercular necrosis, the urine sodium will be more than 40. And in pre-renal, the fractional excretion of sodium will be less than 1%. Again, in acute tubercular necrosis, the fractional excretion of sodium will be more than 20%. And about the urine osmolality, in pre-renal, it will be high. And again, in acute tubercular necrosis, the urine osmolality will be low. And the pre-renal patients will respond to IV fluids, but acute tubercular necrosis won't. And about the improvement, the pre-renal patients will get improvement, but there will be no improvement in acute tubercular necrosis. Let's talk about the management part. So step 1, first of all, we have to identify and treat the cause. First, we have to identify and treat the cause. We have to give IV fluids for dehydration. We have to give antibiotics for sepsis, and we have to stop the nephrotoxic drugs like NSAIDs or aminoglycosides. And if there is any obstruction, we have to relieve the obstruction by surgically. Now I'll talk about the fluid management. So if the patient is hypotensive, if his systolic blood pressure is less than 90 millimeter of mercury, or the mean arterial pressure is less than 65, we have to start IV crystalloids like normoxidine or ringal lactate. Then we have to monitor urine output, blood pressure, and central venous pressure if needed. And then we have to manage the complications. Like there are certain complications that occurs in acute kidney injury. Like one is hyperkalemia. For hyperkalemia, we have to give injectable calcium gluconate, then insulin plus dextrose infusion, and we have to nebulize with salbutamol. We have to do all these to control hyperkalemia. Again, for metabolic acidosis, if there is metabolic acidosis, it is also a common complications seen in AKI. We have to give sodium bicarbonate if it is severe only. And if there is fluid overload, we have to give injectable diuretics like furosemide. And dialysis if there is severe fluid overload. If needed, we have to go for dialysis. Now, the question is that when to start dialysis? It's a very important section. We have to know when to start dialysis in AKI. So we have to remember the mnemonic like AEIOU. So A is acidosis. If the acidosis is severe or refractory, we have to go for dialysis. E, if the electrolyte imbalance. If potassium is more than 6.5, we have to go for dialysis. And again, I for intoxication. If certain toxicity, the intoxication is much more, we have to go for dialysis. O, overload. If the overload causes pulmonary edema, we have to go for dialysis. And U, and for U, it's uromic symptoms like encephalopathy, pericarditis. If it's there, then we have to go for dialysis. Now let's talk about the prognosis of AKI. So how the prognosis in acute kidney injury. So if the acute kidney injury is pre-renal, it's usually reversible. But in acute tubular necrosis, it will take weeks to reverse the symptoms of AKI. But if the treatment get delayed, it can progress to chronic kidney disease. Now, I'll give you some tips to prevent acute kidney injury. So the first important tip is to avoid unnecessary use of NSAIDs like diclofenac. And we have to monitor creatinine in high-risk patients like diabetic hypertensive patients. We have to hydrate the patient before any contrast studies. And if there is sepsis, we have to manage it early. The sepsis management should be early. We cannot delay it. Usually, if you are suspected of any sepsis, the treatment of sepsis or the antibiotic should be started within 1 hour. So, let's come to the conclusion. So, AKI is not just a lab value, it's a warning sign. Early recognition, correct classification, and timely intervention can save kidneys and lives. So, this is all about acute kidney injury. I hope you like the video. Kindly do me a favor by like, share, and subscribe this channel. Thank you so much.